at a really important topic, which is those instances when psychedelic experiences can possibly be traumatic and even lead to PTSD. Now, we know that psychedelics have the potential and can sometimes heal trauma, but they can also occasionally cause it because these experiences are terrifying, overwhelming, and so on. I personally was diagnosed with PTSD after a kind of very frightening psychedelic trip when I was 18. So I'm familiar that this can happen, but up to now, this has been one of these critical research gaps on this topic. So I was really pleased that there's now, two research papers, one that's been published, another one coming out, exploring this topic and different aspects of this topic. So, first of all, Abigail Calder, who is a PhD at the University of Freiburg, is going to be presenting her paper that has come out. While Abigail's talking, I'll post the link to the paper in the chat. Abigail will be talking for 10 to 15 minutes, or possibly up to 20. And then Ricarda Evans, who is a therapist and researcher at the Humboldt University in Germany and also runs a clinic for people with post-psychedelic difficulties, will be presenting her team's research on PTSD as a complication after psychedelics, which is going to be coming out soon. Right. Well, with that, I'm going to hand over to Abigail.
Great, thank you very much. I'll try to share my screen. And please excuse my voice, I'm getting over a cold. I hope you can still hear me okay. Can everyone see my slides? Yes, perfect. Okay. So today, I'm basically going to be presenting the case that some post-psychedelic difficulties are best understood as psychological trauma. I may be preaching to the choir a little bit, but at least I'll give you the arguments that maybe you can also present to other people. So I plan to talk for about 15 to 18 minutes or so. And at the end, you'll get also a link to the book chapter that I recently co-authored about exactly this topic. So before I can lay that out, we need a definition of psychological trauma. And psychological trauma, generally speaking, has two components. The first is that it follows a traumatic event. It's, I think, the only psychological disorder that has to be connected to an event. And we can just use the so-called official definitions of what a traumatic event is because they serve our purposes here. The DSM-5 and the ICD-11 define this slightly differently. In the ICD-11, a traumatic event is extremely horrific or threatening. So they leave it kind of open to interpretation. The DSM-5 is a little bit more specific. They say a traumatic event is exposure to actual or threatened death, serious injury, or sexual violence. You might wonder how that could apply to psychedelics, and I will point out the phrase or threatened. Threat is subjective, and I'll come back to that. So that's the first.
By the way,
yes.
if you want, at the moment we see the next slide as well, but so it works fine now. But I don't know if it's possible.
You see presenter view.
I guess it's presenter view, yeah. Which is
yeah.
fine, but if there is a way to do it into full screen,
I would also prefer
there's more suspense.
Here. Now do you see the proper one?
Perfect.
Perfect. All right, thank you. Now you can be in suspense and you won't see all the notes I made. Okay, so the first aspect of psychological trauma is that it follows a traumatic event. The second aspect is that psychological trauma is associated with certain types of symptoms. And in both the ICD and the DSM, these are divided into 5 clusters. There's re-experiencing, like PTSD flashbacks, avoiding reminders of the event, hypervigilance, various changes in mood and cognition that people experience as negative, for example, anxiety and depression, and dissociative symptoms like derealization and depersonalization. And really important for this first part today is that these symptoms are not always PTSD. They're also not usually PTSD, actually. PTSD is an extreme and very specific form of reaction to a traumatic event, but it's actually a lot more common for people to develop depression or anxiety or subclinical issues after a traumatic event. And of course, many people also recover completely. But when people have symptoms after a traumatic event, and those symptoms are in these 5 categories, we can speak of them as a reaction to trauma. So with this in mind, what about psychedelics? Let's get to the first part. Can a trip be extremely horrific or threatening? I think we all know the answer to that. Yes, obviously it can. There are many descriptions in both the scientific literature and elsewhere of psychedelic experiences that are extremely horrific or threatening. I included two quotes here. One is from Argyri's study from last year on ontological shock. She actually has many quotes of people who are clearly describing very overwhelmingly horrifying experiences. This person said the magnitude of the fear and the panic was unlike anything I've ever encountered. So it's an extreme experience, clearly. This can also sometimes escalate to feeling like your life or your sanity is threatened, which fulfills the DSM-5 criterion for trauma, in addition to the ICD-11. My favorite example of this is actually Albert Hoffman's first trip, Bicycle Day. He was afraid that he was dying, and just because of the nature of the psychedelic effects, this fear was very convincing at the time. So there's a subjective fear that this is it, and that can be traumatizing, although of course in his case, he was doing very well afterwards. So how does this happen? As you probably know, psychedelics can amplify feelings in general, and oftentimes that's positive feelings, but sometimes it's not. Sometimes it's feelings of fear, horror, helplessness, especially in a bad setting that's not really equipped to stop this from escalating. Those feelings can just escalate to an almost unimaginable degree until people feel like they're stretched to the maximal possible human suffering. Many people who have these types of experiences also report some fear of permanent damage. I mean, at some point, if you're suffering badly enough, it can seem unimaginable that you would just go back to normal afterward. It's not uncommon for people to fear that they've broken their brain or even been spiritually damaged in some way. And all of this can seem highly convincing and immersive when you add in effects like time dilation and maybe a lack of knowledge about what exactly to expect from the drug effects, etc. In general, we differentiate three different but interacting causes of traumatic psychedelic experiences. Firstly, there's the drug effects themselves that can just be frightening or amplify fear. Secondly, sometimes external events are playing a role. This can mean, for example, that somebody reacts particularly strongly to something that normally wouldn't be so difficult, like an interaction with the police, or an example from the Psychedelic Science Conference that I heard was that someone wanted their therapist to hold their hand during the experience, and the therapist refused. And that caused a spiral of negative emotion and also some re-traumatization. Re-traumatization is number three. Sometimes during a psychedelic experience, previous trauma can emerge again. And this is also an important therapeutic mechanism. When it's managed well, it can lead to healing. But when it's not managed well, it can sort of deepen the trauma. All right, so that deals with point one regarding psychological trauma. The second question is, are horrific trips followed by trauma-related symptoms? Because if they're not, then we would not say that they're traumatizing. And as you might infer, the answer to this, I think, is also yes. We know this from the data on post-psychedelic difficulties. Most post-psychedelic difficulties follow highly challenging experiences. For example, from Jules' study, they showed that 3/4 of people who had these difficulties said that they happened after a, I think, very or extremely challenging experience. So this is probably a reaction to the experience. It's not drug toxicity. It's another type of reaction. And in some unpublished data that I actually just presented at Psychedelic Science last week, we saw that the severity of a challenging experience was the single greatest predictor of adverse effects at every time point up to 1 month after the trip that we measured. So there's a relationship there. And last but not least, many common post-trip difficulties are in fact in these 5 clusters of trauma-related symptoms. Some are not, I'll mention that. Like for example, mania or some HPPD symptoms are not really related to trauma probably. But many of the most common symptoms do seem like they could be, even if they don't fulfill the criteria for PTSD. So I want to walk you through these 5 clusters now and what we know about post-trip difficulties in each of these 5 categories. I think the most obvious one is the negative changes in mood and cognition. We see in multiple studies that anxiety is the most common post-trip difficulty. Also, our new unpublished data found the same thing. It was the most common, and it may affect up to 81% of people with post-trip difficulties in previous studies. Other times people might report depressive symptoms, guilt, shame, feeling isolated, and various changes, negative changes in their beliefs or the expectations about oneself or about the world. That includes fear of having broken one's brain. And of course, all of these might interact with the cause of the traumatic event. You might see different types of symptoms in somebody who'd been in a car accident versus someone who was assaulted versus someone who had a traumatic psychedelic experience. But all of these have been reported in various studies of post-trip difficulties. In the DSM and the ICD, both of these next two symptoms are required for a PTSD diagnosis. People can also have them without the diagnosis, but they are kind of the core symptomology of PTSD. Re-experiencing means having intrusive or distressing memories of the experience, or distress at reminders of it, or nightmares related to it. And all of these have also been reported after really bad trips on psychedelics. And note that these are not the same thing as perceptual flashbacks or HPPD. So it's kind of an unfortunate naming convention that psychedelic flashbacks and PTSD flashbacks are both called flashbacks because they're not the same. Here we're talking about flashbacks in which people feel like they're re-experiencing the psychedelic trip and that they feel distress at that. Avoidance symptoms have also been reported in some studies, particularly fear or avoidance of specific events or objects related to a psychedelic experience. This is probably the least well assessed in studies so far, but maybe Ricarda can also help us out with that later. And the last two symptom clusters are hyperarousal and dissociative symptoms. So hyperarousal is things like sleep disturbances, difficulty concentrating, hypervigilance, irritability. Particularly sleep disturbances seem relatively common after extremely challenging psychedelic trips, also difficulty concentrating. And the dissociative symptoms for me are also some of the most interesting ones because they're also some of the most trauma specific. Many of these other symptoms are not particularly specific to trauma. You can have sleep disturbances for many reasons. You can be depressed without having been traumatized. But dissociative symptoms like derealization and depersonalization have a pretty well-established association with psychological trauma. Derealization, if you're not familiar, is the feeling of detachment from the world, or like the world isn't real, or people might feel like they're in a dream or simulation. It's not usually psychotic, so people usually know that it cannot be that way, but it just feels that way. And sometimes that can make you also anxious or even panic. Depersonalization is similar, but related to yourself. So you feel detached from yourself, or like you are not real, even though you know you must be real. It just feels like you're detached. This may affect around 15% of people with post-trip difficulties, and it seems to also be more common in people who have relatively severe symptoms. And this is true for post-trip difficulties, but also for other types of trauma. It's associated with relatively severe disease. So just to summarize that part, the bad news is I hope I could lay out why we think that some horrific trips can be traumatic, cause symptoms of psychological trauma. One thing I left out is the prevalence. I didn't mention it in the book chapter, at least I didn't try to pin down a number. Here I also won't, but I'll give you an upper bound from studies of post-trip difficulties. So there was a study that came out a couple of years ago by Otto Simonson and colleagues that asked people if they'd ever had a challenging experience that led to impairment, particularly psychological symptoms that lasted a month or more. And in there, 3.4% of psychedelics users reported that they'd ever had such an experience. I'm sure not all of them were reporting traumatic experiences, so the prevalence among psychedelic users has to be under 3.4%. And here I chose the timeline of 1 month because PTSD cannot be diagnosed before 1 month after a traumatic event. Everything before that is acute stress disorder. In our unpublished data that we presented last week, we saw that less than 2% of trips, so not users, but trips, if you ask people to describe a single experience, less than 2% reported negative symptoms that they felt were impairing them 1 month later. And this included symptoms that were not trauma related. So it has to be under 2%. It might be way under 2%. We don't know. That's the bad news. The good news is, I will emphasize, most people don't develop lasting trauma or PTSD. Most adults who experience a traumatic event of any kind don't develop PTSD. And all data points to the hypothesis that most people don't develop symptoms after a potentially traumatic psychedelic experience either. That doesn't mean we don't care about the people who do, but it means the prognosis is generally good. And we can also benefit from existing knowledge about trauma if we frame these types of experiences as trauma. We already know quite a bit about trauma. And so, with that in mind, I wanted to say a couple of words about prevention of traumatic psychedelic experiences and what helps people recover from them. This part is going to be woefully inadequate for time reasons, but also because we don't know that much about what helps people specifically after psychedelic experiences. But there are some things we do know. Firstly, how do we prevent trips that are horrific or threatening? There's already quite a bit of literature on this. We all know the adage about safe and supportive settings, and of course about also using reasonable doses. Previous research suggests that dose is strongly related to how challenging the experience is. And so maybe we don't start people off on 200 micrograms of LSD if they've never tripped before. I think that's pretty reasonable advice. I would mention two other things. First of all, educating people about what psychedelics are likely to do is really important for preventing feelings of overwhelm and helplessness that can end up being part of a traumatic experience. We have to manage people's expectations. And just reading through people's descriptions of traumatic psychedelic experiences, there are definitely quite a few that seem to relate to just lack of knowledge about the drug effects. For example, somebody doesn't really know much about ego dissolution and they mistake that for actually dying. Can happen relatively easily if people are not prepared. One thing I also really like to emphasize, and I hope there will be more research on this in the future, is navigational skill. I think tripping is a skill, whether you're in a clinical trial or therapy or somewhere else. It's a skill that can be learned and should be taught. I think often people are directed to just let go and trust the experience. And sometimes that's good advice because it has this kind of paradoxical effect that letting go of control can sometimes assert control over the experience by making it smoother. But that's not the only way you can control an experience. And previous research on trauma shows that when people are in a scary situation and they feel helpless, they may be more likely to develop PTSD afterward. This may apply with psychedelics as well. And so I think it's really important to expand the toolbox of ways that people can navigate their psychedelic experiences. Breathwork can be useful, various types of movement, meditation, etc. I put a list here. And one thing we emphasize also in our lab is active interaction with the experience. So we remind people, you don't have to just let go and let it happen to you, because this can often kind of facilitate feelings of helplessness. You can try to actively interact with the experience in various ways. And often that gets an experience moving. It doesn't get so stuck in a scary place that makes people feel helpless.
You're at 15 minutes, by the way, Abigail.
Yes, I see. I'm at 16 minutes. I will be fast. So let's say all of this fails and a really horrific experience happens. What can you do right afterward? Immediately afterward, if you ever encounter someone in this situation, it's important that feelings of threat end as soon as possible and that we calm their nervous system down, for example, using relaxation techniques. What's also really important is social support and not overreacting. This is, again, all knowledge from previous trauma research that shows that if you make somebody process or talk about a traumatic experience that just happened before they're ready, that can actually be harmful. The good news is, even after such an experience, as I mentioned, it seems like most people are going to recover. And that's another reason not to overreact right away, because there's almost no intervention immediately after a traumatic event is proven to prevent PTSD. And many people have their own coping mechanisms that they can and will use. And we don't want to get in the way of that. As far as long-term recovery, there's almost no data on psychedelics specifically. On other types of trauma, the most evidence-based therapies are CBT, exposure therapy, and maybe even EMDR. And regarding psychedelics, there are a bunch of psychedelic integration techniques that have not yet been well studied. But I find them interesting because many of them put an emphasis on meaning making, and many people point to meaning making as a mechanism by which they make a scary experience, well, in which they turn it into something good and recover, which is a bit reminiscent of post-traumatic growth. I think there's a lot of parallels between how people describe post-traumatic growth and how they describe recovery from many challenging experiences when recovery goes well. Some research that we saw presented here a couple months ago also suggests that what helps may depend on the symptom, but we really need more research on the long-term recovery. Okay, so I hope that was a good overview on traumatic psychedelic experiences. Just to conclude, I think traumatic psychedelic experiences are real, and the evidence in favor of that is pretty strong. A minority of these, let's say, potentially traumatic, horrific psychedelic experiences cause lasting symptoms that resemble psychological trauma. Anxiety is the most common, and most people don't develop PTSD, which is good. And I would say prevention and recovery are possible. So there's some optimism and some hope to all of this as well. Thank you very much. Here is the citation of the full chapter. It's behind a paywall on Springer, but I put a free one on ResearchGate. And if you can't find it, message me. I will give it to you.
Fantastic, Abigail. Very interesting, important research. There's a lot of, some points there to really dive into as well. We're going to go on to Ricarda, and then we will have 20 minutes for Q&A at the end. And Abigail, by the way, if you want to answer some questions in the chat, you can also do that now. Okay, Ricarda, over to you. So you're muted at the moment, Ricarda.
Okay, now it should work. Can you hear me? Great. And can you also see the full screen of the slides? Great.
Yes.
So thank you very much, Abigail, for this great first talk. And thank you to Joy and Jules for organizing this event. It's a very important topic to me that I've been dealing with since a couple of years ago. And as Jules just mentioned, I was always also surprised why this hasn't caught more attention in the research world. So I want to start my presentation with a quote by the German pharmacologist Gustav Kuczynski that roughly translates a drug that is claimed to have no side effects is under strong suspicion of also having no primary effects. And psychedelics are extremely powerful substances, as we have seen in many clinical populations now. And so with those powerful substances, it's not only plausible, but kind of expected that for some users, these effects may be negative. It really seems to me like two sides of the same coin. And in my clinical background, unrelated to psychedelics, I'm a specialized clinician in treating people with PTSD. So I was always kind of surprised why there's not any research on this topic, given there are so many similarities between some of the symptom descriptions and PTSD symptoms, as Abigail just showed in her talk. So I thought we should start a project, and today I want to present results from an online survey that covered exactly that topic. So I think I'll skip the background section totally because I think Abigail in her talk really described very well why it makes sense to think that psychedelics can cause PTSD. So I just want to show this overview of PTSD diagnosis according to DSM-5 very quickly, as it's also central to our study. And as Abigail already mentioned, for PTSD diagnosis, people need to show a specific pattern of symptom clusters after experiencing a traumatic event. And we have 4 symptom clusters: the intrusive memories, hyperarousal, avoidance, negative thoughts and feelings. And we have a duration that needs to be longer than a month. And we need to have clinically significant distress or impairment in social, occupational, or other important areas of functioning. And while many surveys on the group level already observe that we have symptoms from all of those 4 clusters. What has not really been established in previous research is to see if they were also on the individual level present, like all 4 clusters in patients. So the key research questions of the survey were, can certain challenges after psychedelic experiences be actually considered a form of PTSD? And if that's the case, what exactly constitutes a traumatic event in these situations? How does the intensity or content of a psychedelic experience relate to the issue reported later on? And which strategies did people use to find relief and what worked for them? And that's what I want to present in the upcoming slides. To answer the questions, we designed an online survey available in English and German language, and this was aimed at people over the age of 18 who had previously used psychedelics, including classic serotonergic psychedelics, but also substances like MDMA or ketamine, and who had encountered at least one challenging or traumatic experience with psychedelics, which continued to burden them even after the acute effects of the substance had subsided. And this is important because the sample was not addressing all users of psychedelic substances, but just a subgroup who already reported that subjectively they had a challenging or traumatic experience and continued to face difficulties after the acute effects. Here you see an overview of the survey content. So we asked questions about demographics, about use patterns, aspects of set and setting. We asked questions to specify the trauma type. I will explain that in a little bit more detail when we see the results. Then we asked questions about the acute experiences. We assessed the amount of challenging experiences with the challenging experiences questionnaire and the acceptance, avoidance, promoting experiences questionnaire. We also had free text descriptions of the acute experience. And then we assessed the post-acute problems with the PTSD screening. It was the PCL5. And since the PCL5 doesn't assess a criteria F and G, this is the time criterion and the clinical impairment criterion, we also added questions to assess those. We added an HPPD screening. This is not going to be part of the presentation today, though, but if you have questions to that, I have some backup slides. And we also had a free text description of subacute problems. And we asked for diagnosis before and after the index experience. And in the end, we asked for therapeutic intent. And because we were thinking, well, there's not only post-traumatic stress, there can also be post-traumatic growth. We also wanted to assess a little bit in this area, and then we used the post-traumatic growth inventory. So 243 participants finished at least the PTSD section of our survey and were included in the present analysis. The mean age of the group was 38 years. We had slightly more male participants, which is quite common in this kind of online surveys. Most participants were from Germany and the US, followed by UK, Switzerland, and Austria. So we have, quite Western-dominated population here in our survey. So let's get straight to the main question. And I want to guide you through this figure to explain it. So in our sample, and that's just like the first part of the figure, 98% of our survey participants reported at least one PTSD symptoms, which is not really surprising given that we only included people that reported problems after a difficult experience. 78% reported at least one symptom from each of the 4 PTSD symptom clusters I mentioned, including intrusive memories, avoidance, negative changes in mood and cognition, and hyperarousal. 56% had a symptom severity score of 33 or higher, which is considered the clinical cutoff for PTSD symptoms in the PCL. 54 met both the cutoff and reported symptoms across all 4 symptom clusters. 44% additionally reported that symptoms had lasted at least 1 month. And finally, 31% of participants who had experienced a very challenging psychedelic experience with ongoing problems met the full diagnostic criteria for PTSD. including functional impairment in important areas of life. So when in the upcoming slides, I refer to the PTSD group, this is the group I'm talking about. However, it's, I think, very important to keep in mind that also the other 70% in this group that I refer to as non-PTSD group are not unaffected, but they just do not fulfill the full diagnostic criteria for PTSD. But as you can see here, most of them at least have one PTSD symptom. So looking at symptom duration, we found that for most participants, symptoms lasted well beyond 1 month. Half of the sample reported symptoms lasting more than a year, and 18% experienced them for over 5 years. So we have quite chronic cases here in this sample. Yeah, but what was a traumatic experience? So we asked participants, what was the most distressing part of the experience, the part that caused suffering afterwards? And we provided 4 options that we had thought of before as being maybe important. So the majority of participants said that it was actually the psychedelic experience itself that was the most distressing aspect. For example, feelings of dying, losing control, going insane. The next largest group, however, said it were painful memories that resurfaced during the experience. And those memories were what caused the later distress. And the largest subgroup in this memory group recalled instances of sexual assault. And very interestingly, 45% of those had no memory of the event prior to the psychedelic experience. And the average age at the time of the remembered event was significantly lower in the group without previous memories compared to those who already remembered the event before. So those people who had a new memory were on average 6 years when that newly remembered event happened. And those people who already had remembered the event before reported to have been 17 years when the event had happened. And only a small number of participants in our sample said that their post-psychedelic suffering was primarily caused by external events that occurred during the psychedelic experience. And here it was quite interesting that when we asked what the event was, the majority of people did not choose one of the typical traumatic events that you can assess with the life event checklist, but checked other. And then when they explained what they meant, they often described perceived interpersonal threats, such threatening behaviors from other persons who were also under the influence of psychedelics, difficult interactions with the police while they were under the influence of psychedelics, or actions of practitioners or facilitators that were not consented. And in terms of perceived danger, 1/3 reported a reduced perception of danger, while 44% reported an increased perception of danger. And in retrospect, so after the psychedelic experience, 1/3 rated the situation as not at all, only somewhat dangerous. Another third is moderately dangerous, and 37% is very dangerous. So what substances were involved in these difficult experiences? The majority of participants reported using LSD and psilocybin, which makes sense as they are the most widely used psychedelics. However, we did not observe any significant differences between the PTSD and the non-PTSD groups in terms of specific substances. Interestingly, however, about 1/3 of our sample reported to have taken multiple substances, multiple psychedelics in this case, often combining a classic psychedelic with cannabis. And when we looked at the reported dosages, only very few participants reported having such intense experiences after taking a very low dose of psychedelics. However, it also doesn't seem to be necessary to take an extremely high dose to experience lasting negative effects. And we found that these long-lasting problems occurred in both inexperienced and highly experienced users, though the proportion of people that later developed PTSD was slightly higher among those who had never taken a psychedelic before, but this was just significant a trend level. When we compared the PTSD group and the non-PTSD group, we observed that the PTSD group was a little bit younger, 34 versus 40 years old, and the non-PTSD group had less of a higher education, although their education was still quite high, but the non-PTSD group had an even higher education level. The PTSD group also reported more non-psychedelic concomitant substance use. There were no differences in use settings. However, we found a difference in use motives. We've observed more escapist and less self-exploratory intentions in the PTSD group. So I know these numbers can sometimes feel a bit distant. So I'd also like to share a few examples of how participants describe their post-psychedelic symptoms in their own words from the free text sections in the survey. It's now been 3 months since my retreat. I continue to have constant anxiety with consistent flashbacks. My anxiety shows up as claustrophobia. I can't wear necklaces or tight clothing, an inability to breathe, like something is sitting on my chest, overheating, a feeling of panic, constant intrusive thoughts. I will flashback and be back in my journey 1 to 3 times a week. I'm having fewer nightmares, but I do still have them. Another person writes, I suffer from severe anxiety and derealization, depersonalization, dissociation. Several times a day for the past 7 years, I feel as if I'm again experiencing the ayahuasca ceremony. I feel as if I'm in a different dimension, away from everyone around me. It happens mostly when I think about the event, or when I hear music, smells, or conversations about ayahuasca of different dimensions, etc. It seriously impacts my life, and I can't do the things in my life that I wish to do. Another person wrote, I had horrible flashbacks. I cried a lot and felt very distant from people. I was easily triggered into tears if something happened in my family or my partner. I re-experienced the experience and kept wondering why I had to go through that. I could not make sense of it all. And even though I took support and talked openly with my partner and friends, the flashbacks kept happening and I felt really horrible. I brought 2 more. One person wrote, panic attacks, social anxiety, dissociation and derealization, nightmares, existential confusion about my identity and meaning of life, depression at loss of social abilities, fatalism, suicidal thinking, fear of permanent damage, substance abuse, alcohol to mask symptoms. And the last description is from a person who experienced memories coming up. In the 2 months after recovering the memory, I experienced the following: near constant flashbacks, traumatic nightmares, the recovering of countless other traumatic memories, nausea, vomiting related to shame, restlessness and insomnia, panic attacks, paranoia, an impending sense of doom, random bouts of crying and of euphoria, spiritual openness, and constant terror. I ended up going to inpatient treatment for 2 months, which in many ways saved my life.
It's been 15 minutes, by the way, Ricarda.
Right. Okay. I'll finish up soon. Thanks. So I maybe just want to show the last slide because I think it's also quite interesting, and maybe some of you also ask yourself, well, what's the relationship between the acute and the post-acute experiences? So what we found was a strong association between the intensity of the challenging experience and later distress. The more difficult the acute experience, the more PTSD symptoms were reported afterwards. And since the psychedelic experiences are quite complex, we also took a closer look at the acute experience and examined the role of avoidance and acceptance related experiences using the RPEC. And if you're not so familiar with the RPEC, I also put some sample items on the slide. So what we observed was the more avoidance participants reported during the acute experience, the stronger their PTSD symptoms were afterwards. And conversely, the more acceptance-related experiences they had, the fewer PTSD symptoms they reported. There was no significant interaction between the two predictors. And lastly, I also want to look at the post-traumatic growth. And here we found, interestingly, no significant association between the intensity of acute challenges and the post-traumatic growth. So in other words, difficult experiences per se do not predict growth, even though we actually observed post-traumatic growth in both groups, in the PTSD and in the non-PTSD group, although it was slightly higher, of course, in the non-PTSD group. However, there was a very strong positive link between acceptance-related experiences during the trip and later post-traumatic growth. So the more acceptance participants experience in the moment, the more growth they reported afterwards. Avoidance-related experiences, on the other hand, showed neither a strong positive nor negative association with post-traumatic growth. So I think this is an interesting finding, as it challenges this common notion that all challenging experiences are ultimately helpful. It suggests much more that it's not the difficulty of the experience itself that matters, but how it's processed. So growth appears to follow after acceptance and not avoidance. Here you see what participants who had the PTSD diagnosis in our sample reported, what they have tried in supportive measures. And talking to friends and family, as well as searching for information about their symptoms online, were the most common reported strategies. However, only 12% found internet-based resources very helpful, which is not too surprising to me, given that there's pretty much no information on post-psychedelic PTSD available. So the most helpful therapy approach reported was psychotherapy. And among participants with the full PTSD criteria, 70% had actually tried psychotherapy, which is great to see, especially considering that psychotherapy is first-line treatment recommended by most international guidelines. Although in this survey, we don't know what kind of therapy they receive. So I maybe skip the summary and go straight to why are these findings important. And when we advertised our survey, we received many comments along the lines of, I've had many experiences with psychedelics and they all went fine. You are exaggerating the problem. And yeah, I just want to say a few words to that because, yeah, it's true. The vast majority of psychedelic users will likely never develop psychedelic-related PTSD. But that doesn't really help the ones who do. And it's not so much for me about labeling or pathologizing normal processes of integration or adjustment, but I think it's about recognizing when people are genuinely struggling and finding ways to support them more effectively. And so if you understand the nature of post-psychedelic difficulties and post-psychedelic PTSD a bit better, we can also offer better, more appropriate care. And the field of PTSD research has developed over decades now and really provides a solid foundation of knowledge and therapeutic approaches for addressing possibly also psychedelic-related trauma. So this brings me to the end, and I want to take a moment to also say thank you to the team that I did the survey with, Abdo Uya, the PhD student in the lab, and Franziska Dambeck and Emily Goslau, master and bachelor students, and we discussed and received feedback from very nice colleagues in Berlin who are also in the world of psychedelics, Dimitris Repantis, Max Wolf, and also Ulrike Lüken. So if you're interested in this research, we also want to warmly invite you to take part in our new survey on psychedelic flashbacks. Yeah. And if you have any further questions, please also don't hesitate to reach out after the talk.
Thank you very much, Ricarda, and to Abigail as well. Okay, well, look, we've got some questions. We've got about 10 to 20 minutes, depending on people's time, though I know a lot of you will have a hard stop at 11. One question was about, given the findings, then, let's say we're persuaded that psychedelic experiences can be traumatic, can lead to psychedelic trauma or to PTSD sometimes, though it's encouraging to see that it doesn't seem to happen that often if Abigail's kind of unpublished findings are right. But if we accept this, both of your findings, what kind of therapy might be helpful, do you think, for helping people recover? What kind of actions or interventions?
Yeah, I mean, there's no evidence on that yet, so it's just the answer is just based on theoretical ideas. But I mean, for me, there's no reason to assume that we must treat psychedelic-related PTSD much different than we treat other forms of PTSD. And there are um, just very well established intervention strategies for PTSD, and they all have in common, even though they're a little bit different, they all have in common that they're trauma focused, that you somehow go and revisit the trauma and discuss changes in thoughts that appeared after the incident, pretty much. So now, to me, I would say it would completely make sense to just use what we already have and apply this. I think it would just be helpful if the people that do this kind of therapy are aware of what are psychedelics, what are their effects, for example. I think this could sometimes be challenging for therapists if they have no ideas about psychedelics and then have to treat a psychedelic-related PTSD case.
That makes sense. Yeah. Abigail, anything you'd like to add?
No, that's about what I would have said as well. There's just unfortunately no data, and I agree that we should start with what works for normal, quote unquote, normal PTSD.
Okay. Rohan, do you want a question? If I could ask everybody to keep their questions brief, just so we can get through maybe 3 or 4.
Yeah, thanks, Jules. I'll make it quick. Yeah, Abigail already answered a little bit, but maybe Ricardo's got something to offer as well regarding HPPD. I was just wondering what your guys' thoughts are on the association between psychedelic trauma and HPPD. Could it be the case that if your HPPD arises co-occurring with symptoms of PTSD as the result of the psychedelics, could it be in that case it's related to PTSD? What do you think?
Mm-hmm. I can actually give a quick answer on that because we collected the data. I did not present them in my slides, but we also did a screening for HPPD in our survey. And what we actually observed was that we could differentiate PTSD and HPPD quite well. So there was a group of people that really just had PTSD, no HPPD symptoms. But what we also observed was that in the PTSD group, there was a higher percentage of people that also had HPPD symptoms. And those people who had PTSD and HPPD symptoms usually had also a higher intensity of symptom severity. So those who also have HPPD symptoms usually have also more PTSD symptoms. But there are also cases who just had HPPD and no PTSD. So we have PTSD, PTSD plus HPPD, just HPPD, and people that have none of those.
And in the people with just HPPD, was there the trip didn't seem to be as traumatic as what you're saying?
Yeah, so I mean, they entered the survey because they said they had a challenging experience, but then they did not fulfill the PTSD criteria. So it's a little bit difficult to say whether the HPPD symptoms were related to the experiences, because we do not have people in our sample that did not have a challenging experience, because this was like necessary to enter the survey.
Abigail, anything you want to add?
Yeah, I would add, it seems like there's a bit of a split in the field. I remember when we were drafting this book chapter, our editor was Tomislav Majic, who is in Berlin and who was running an integration clinic and who sees clients with HPPD. And we had kind of forwarded this idea based on some previous research that many cases of HPPD might be PTSD. And he kind of pushed back a bit. He said, a lot of the patients I see don't have trauma symptoms, and many of them got HPPD also after a positive experience. And therefore by definition it can't be trauma. So I think it's probably also an overlapping Venn diagram. There seems to be a relationship there, but not everybody who has HPPD had a challenging experience.
David.
Just to add to that, you can get HPPD from non-psychedelic drugs as well. But Ricarda, could you tell us about the proportions of those, if you have that data accessible, of the HPPD and trauma, and just the trauma, just to give a sense of the relative sizes of those groups? That'd be great. But no problem if not.
Yeah, so if you like, I could just show you the slide. I have it in the backups actually. Just so here you see the same slide that I already showed, but you see that the darker blue are the people that reported any HPPD symptom. So so any HPPD symptom was also quite frequent, as well as like any PTSD symptoms. But if we look at, let me go one slide further. Full HPPD, like all criteria that are mentioned in the PTSD, then we actually find just like in the group of the PTSD people, like around 28% also had a full HPPD screening diagnosis. So we just did a screening for HPPD in the surveys, and this was much lower in the non-PTSD group. So just to get an idea of the numbers.
Great, thank you very much.
Okay, Arian.
Thanks so much for this presentation. Can you hear me? Am I audible?
Yes.
Okay, yeah. Sorry, I'm supervising some trainees, so I had to duck out in the middle of Abigail's talk. So sorry about that. Ricarda, I'm curious about, you mentioned earlier that treating post-psychedelic trauma may not be that different from treatment as usual as it pertains to trauma. I guess I'm curious about exposure therapy. And if you have thoughts on that, exposure therapy being a very common first-line therapy modality for PTSD. And what I'm hearing about this, spectrum of avoidance and acceptance, I could see it being useful. I could also see it maybe not being useful. I'm curious if you have opinions on it.
Yeah, I mean, there are not really a lot of case reports on that, but I mean, you definitely could also do a memory script of a psychedelic experience. And I mean, there are also other traumatic events unrelated to psychedelics that maybe have, or where there are like lacks, or where there are gaps in memory. And I think this is maybe more common in psychedelic experience, that you don't really have like a timeline of events of your psychedelic experience. But I think this could be a little bit challenging in the beginning. What we would do in non-psychedelic cases to just accept that it's also okay to have like those gaps in memory. Yeah. So I think that this is something that you could try, but I don't know any trials with that. And I think the problem here is also that the cases, the regional cases are very low, because yeah, as you saw, we did it, the international survey, we had 243 cases. We just don't see enough cases to do like a big trial on them.
David. You're muted at the moment.
I was just going to say, thank you all for your talk, Ricarda and Abigail. Really appreciated it. Kind of following up on Vlad's question here about manifestations of existing psychological difficulty. And of course, this is a difficult thing to measure, but I'm wondering if you all had a sense of this at all. Ricarda, I know you said about 76% of individuals said the trauma was actually the psychedelic experience itself, but that doesn't necessarily tell us, is this an area where they have struggled before, an area of difficulty, of stuckness, that sort of thing? And is that something you got a sense of either narratively, or through looking at predictors of previous mental health diagnoses or difficulties prior to the experiences?
So we do have open text fields where they describe the acute experience and what they experience as difficult. We do not have them fully analyzed yet. But when you asked about previous mental health diagnosis, what I can say that, so we asked what kind of mental health diagnosis they had before. And in terms of number, the PTSD group actually had a slightly higher number of diagnosis. It was around 60%, which was at trend level higher than the non-PTSD group. But also the non-PTSD group had quite a high number of pre-index experience mental health problems. So I think in our sample, around 50 to 60% had a pre-existing mental health diagnosis. Yeah. So this could maybe also be just a general risk factor for actually having a very difficult experience.
I would just add that I think it depends on what you mean by deep psychological or emotional conflict. If you read descriptions of these potentially traumatic experiences, many of them seem to have an existential component. And existential questions could be described as deep conflicts that everyone struggles with. For example, fear of mortality, or the idea that you cannot fully control your own mind, and these types of things. So it seems like the answer has to be yes, but at the same time, it may be conflicts that pretty much everybody encounters, and it's not something that's specific to that individual, at least not always.
There may also be cultural issues. We're just not used to extreme ecstatic experiences in our culture, so it can feel like you're going crazy. Whilst other cultures, these are going to be culturally normal, and you're going to go back after the ritual to a culture where it's normal, while we're going back to a culture where people might sound crazy to other people as well. So all of that makes it more likely to be traumatic. Well, there's lots more we could discuss. We could, if we had time, I'd love to ask about, flashbacks and to what extent these could be kind of a post-traumatic thing sometimes. Re-exposure therapy through psychedelics, like taking psychedelics again to heal, to revisit the experience. Resurfaced memories of childhood abuse. How, one of the things people struggle with is, are these real memories or, not? But this is quite common on psychedelics, to suddenly have kind of visions of childhood abuse. I think also, I'd just like to congratulate you both on your work on this. This is such an important topic. There was very little published on it at all. So it's so useful that you're doing this research, and it's going to be very helpful to other people as well. We've still got a lot to learn about how to help people recover from these experiences as well. So I'd love, the people in this group to work together on that and think about how to learn what helps people recover over the next couple of years. But it's just it's really encouraging that we're making progress on these topics, and really important. Okay, thank you both very much indeed for presenting this important research. Thank you everyone for coming. I'll send you the recording as well, and we'll see you next time. I will also share, if it's okay, Abigail and Ricarda's emails. So if there are any follow-on questions, you can follow up with them. Okay, thank you, everybody.
Of course. Thank
Thank
you.
you.
See you
Thank
next
you,
time.
everyone. Thanks, bye.